Honorable government officials, esteemed international and national experts, it's an honor and privilege to be standing in front of you here and speaking on a topic that is very close to my heart. I am Vijaya Mishra. Professionally, I'm a medical biochemist working at the Department of Biochemistry at BP Koirala Institute of Health Sciences, Dharan. I am a board member at Rare Diseases Society, Nepal. But beyond all that, I'm a passionate newborn screening advocate. Year 2010, after losing my firstborn, 9 days of her life, to a preterm delivery, I have known the pain of losing a child. And that pain led to the discovery of my passion for newborn screening. Being a biochemist, I thought newborn screening is a perfect program for me to work and contribute into, and that is what have led me to stand in front of you all here today. Now, before I officially begin with my topic, I would like to ask all of you in this hall, and I believe all of us know the condition hypothyroidism. Let me see a raise of hands if you have anyone in your family or yourself knowing to have thyroid disorders. Anyone in your family or yourself? Yes. And this is the medication which cost approximately Nepalese rupees 290, that is approximately $2 to $3 for 3 months, that could change the fate of a child that is born. I have borrowed this picture from the new Philippines newborn screening program. We can see the children here. Both of them are having congenital hypothyroidism. One detected by newborn screening program and treated on time, and this is her fate. And the other one we can see has a devastating life outcome. And don't we think that babies born in Nepal also deserves a fair chance to life where we can save the baby from facing that devastating condition. 2 days back, I had an opportunity to represent Nepal on a global platform where I had to explain about the newborn screening scenario in the context of to the global platform, where people in the United Nations, United Kingdoms, and USA were talking about whole genome sequencing for newborn screening. Even India is on the line. We and I kept the weak cries of babies of Nepal saying that we do not even screen for congenital hypothyroidism in our country. And that made me, the emotions died in my throat, speaking up for the child in Nepal. So, is it impossible for us to make this dream a reality? Can't we envision a Nepal to have its own newborn screening program? Let us see what the evidence has to say. How far are we from that dream to make it a reality? Why does it even matter? Why are we talking about newborn screening? If we look into the newborn screening and maternal newborn health goals, the Nepal Safe Motherhood and Newborn Health Roadmap 2030, developed by the Family Welfare Division and the Ministry of Health, the goal of that roadmap is to ensure healthy lives and well-being for mothers and newborn and to reduce neonatal mortality rate from 21 to 12 per thousand by the year 2030. And similarly to reduce the stillbirth from 18 to less than 12.5 per thousand by 2030. And the key strategies that has been proposed in this roadmap is that we have to have a continuous system of care starting from pre-pregnancy to postnatal period. And newborn screening is one of the major components that comes in the postnatal period of this program. So the importance of this roadmap is to reduce the neonatal and newborn mortality. It supports the Sustainable Development Goal target for maternal and child health and contributes to universal health coverage and reduce inequities. So looking at the global scenario where US is screening, the coverage is almost 100%. We can see that the coverage from Asia Pacific region is 13%, and Nepal does not contribute to that 13% because we still do not have a national newborn screening program or a registry yet. So let us see what this evidence has to say in regards to literatures in Nepal. I have brought in 9 major studies, which is in regards to the newborn blood spot screening. I've excluded the hearing and the congenital heart defect screening here. So starting with the first article, A Metabolic Disease in Nepal, A Perspective, which was published in 2010 by author Dr. Arti Pandey. And this study highlights certain important points that I would be stating here. Looking at the global IEM prevalence, this was in back 2010, where the prevalence was 1 in 800 to 1 in 5,000 live births. And in 2010, because of the recent improved detection, the number of detection was already 1 in 784 live births. And Nepal, in that scenario, only had isolated case reports. Systematic prevalence data were not available. There is a caste-based endogamy and rural consanguinity in Nepal, which may further elevate the risk of inherited disorders in the Nepalese population and in the babies. However, again, the country-specific data is lacking. There were few case reports already published, which were Wilson disease, beta thalassemia, certain hemoglobin variants, and G6PD-H deficiency. Mental retardation, although we do not use this word, we use the word intellectual disability now. So mental retardation prevalence in Nepal was likely linked to the undiagnosed metabolic causes, and the article highlights that Nepal lacks newborn screening system. It needs identified for the cost-effective pilot screening studies and national newborn screening program. We need to establish the national registry and database for metabolic disorders, build laboratory capacity, which includes the biochemical and genetics diagnostic, incorporating inborn error of metabolism awareness in the medical training curriculum as well. And we need to foster institutional collaboration and public awareness. So this was published in 2010, and we are in 2025 now. How have things changed over these last 15 years? We will be seeing with the updating literature review. So the diagnostic challenges that always remains with the inborn error of metabolism in the babies are, most of the symptoms, they are non-specific, and the laboratory confirmation is essential. And when we talk about the confirmatory diagnosis, sophisticated techniques like tandem mass spectrometry is needed. It is ideal, but again, it is costly. And so it was suggested that we initiate with simple biochemical assay, emphasizing on training healthcare providers for recognition and diagnosis. And in the same article, few important studies were highlighted where Nepalese population were screened, and 1 in 130 screened Nepalese was found to have thalassemia triad. And a study done in genetic clinic study at BP Koirala Institute of Health Sciences, out of the 30 children, 10 of these children were having one or other form of chromosomal disorders, and it was speculated that the remaining 20 might also have some undetected metabolic disorders. Looking at the disability rate, the overall disability rate back in 2010 was 4.87%, and 17.1% of this was likely to be because of the inherited disorders. Coming to the second study, neonatal thyroid screening. So the following 3 articles that I will be presenting would be in regards to congenital hypothyroidism. And congenital hypothyroidism is considered to be one of the most preventable cause of intellectual disability in pediatric population. And when we are able to detect this baby within first 2 weeks of life, the baby is going to develop into a completely healthy adult. But in that absence, the further delay in diagnosis, the intellectual disability, the brain damage would be irreversible. So this short communication by Luna Bhattacharya as author in 2010, she highlights, the author highlights the pilot newborn screening in Nepal, the data as 1 in 5,000 babies to have congenital hypothyroidism, and raising a child with untreated hypothyroidism leads to severe mental, emotional, and physical strain for the families. There are limited national data on prevalence, so a need for larger scale studies in Nepal was recommended. And most children are asymptomatic at birth. The parents only notice the symptoms as the child faces developmental delay. So the diagnosis usually happens 3 to 6 months after their life, and by then the permanent brain damage has already occurred in the baby. So the delayed identification, 6 to 36 months when the developmental delay is noticed, hence early detection and thyroxine therapy was suggested to prevent irreversible cognitive and growth impairment. So again, the same article highlights recommends universal neonatal screening panel, and currently till now the scenario is changing, but only the babies who are born to mothers who have hypothyroidism are tested in our context, and not all the newborns are screened. So the challenges are highlighted as inadequate rural infrastructure for laboratory testing, diagnostic interpretation, treatment, and monitoring, and there is a need for standardized national guideline on screening parameters, timing of sample, and management protocol. And the future direction given by this short communication was, we do not need any further evidence now to implement the newborn screening for congenital hypothyroidism. The next study, this was a study done by myself looking into the hospital data over last 7 years, and we found that out of the 1,243 infants record, 54 infants, that is approximately 4.5 infants, had congenital hypothyroidism confirmed in their reports. And majority of the baby were diagnosed after 3 months of life. So only 32% of these 56 babies were diagnosed early, before 3 months, but the other babies were all beyond 3 months, and we were already late in getting the baby diagnosed and treated on time. So significant proportion of infants had congenital hypothyroidism, both overt and subclinical, and the study highlights delayed detection risk in the absence of screening. There is another screening which used the cord blood sample for the testing of the babies for congenital hypothyroidism, and the study was the first which was done in rural setup by the author in the year 2025. The article was published, and here the results were, the recall rate for positive screening was 1.8%, and the prevalence rate amongst recall tests were 18.2%, and the overall prevalence for congenital hypothyroidism was 0.33%. So the recall rate is higher than the American Academy of Pediatrics recommendation, which is 0.05%. Here it was 1.8%. And the summary of the article is that the cord blood TSS screening shows significant recall rate with low overall prevalence. However, a higher cutoff should be considered whenever we are screening from TSH cord blood, because there is a TSS surge phenomenon that might happen, and a higher cutoff value might decrease the positive the recall rate. And larger population-based study is needed to establish normative cutoff value for this screening approach. So these 3 articles that I brought up was in regards to congenital hypothyroidism, and I strongly, standing here, would advocate for congenital hypothyroidism to be screened as one of the first parameters or disorders to be tested as a screening program for Nepal. The fifth article was screening mentally retarded children for inborn error of metabolism. Again, the author is Naveen K. Srivastava and Dr. Aarti. And the numbers of articles that I have brought in, unfortunately, we do not have Dr. Aarti here with us today. She is currently working as a genetic counselor in the United States, but she has contributed a lot in the field of newborn screening and the papers that has been here that I am presenting right now. So here, the rationale of this study was to screen the higher risk population, children who were already living with intellectual disability were screened to determine the IEM prevalence. And for this study, 2 centers in Kathmandu, the babies were recruited. 62 babies were recruited who were having some form of intellectual disability, and 60 healthy control babies were taken. And these were the clinical profile of the baby: 6 mild, 34 moderate, and 11 severe mental retardation baby, 7 with vision deficit, 1 with hearing deficit, and 1 with cerebral palsy. And the urine of these babies, both the cases and the control, were screened for a qualitative urine analysis, which is simplest, cost-effective method where simple chemical reactions were done in the urine sample of those babies to detect various inherited disorders. And the results were as follows. There were 8 positive PKU, phenylketonuria cases detected. However, they were false positive when run in the paper chromatography. There were 3 positive ketone bodies test. There were 10 positive for alpha ketoaciduria, 2 positive for mucopolysaccharidosis, and 12 positive for fructoseuria. So the pilot evidence suggested that inborn error of metabolism existed in Nepalese population. However, they were underdiagnosed. And simple, cheap, qualitative urine tests are valuable, low cost of tool for preliminary surveillance in resource-limited settings. However, confirmatory diagnoses are essential because we saw few false positive cases for PKU. So the recommendation from this article was implementation of a broader neonatal screening program using advanced diagnostic method like tandem mass spectrometry or fluorimetric-based assay. This was a summary of case reports that were published in regards to the Nepalese population. And again, the author is Dr. Aarti Pandey, which was published in the year 2019. And the author compiled all the and reviewed all the published case report using the ICD-11 classification using Google Scholar and PubMed database. And this was the first comprehensive documentation of inherited metabolic disorders in Nepalese literature, and 443 published cases reports were identified. And this not all the case reports or cases are published in the literature, so there are very high chances a lot of other cases for inherited disorders exist in Nepalese population. So most of the diagnosis for these 443 cases that were published was based on clinical, histopathological, and radiological findings. In the absence of biochemical or genetic testing, the confirmatory testing were not available. So the case reports that were most commonly reported were G6PD-H deficiency, Wilson disease, cobalamin deficiency, various lysosomal storage disorders were detected, mucopolysaccharidosis, oculocutaneous albinism, and factor X deficiency were the case reports that were published, and other sporadic reports like mitochondrial disorders, urea cycles were detected. So the strong evidence, this article also provided a strong evidence base for initiating a pilot newborn screening program for enzymatic disorder. Again, Dr. Aarti, she and the team worked on newborn screening for selected disorder in Nepal, a pilot study. And this was the first pilot study done in Nepal in the year 2019, where approximately 5,000 samples were recruited from the 3 different hospitals in Kathmandu, and the sample was collected by dried blood spot testing and sent to Switzerland for the testing. And the objective of this article was to evaluate the feasibility of the DBS sample collection and analysis, to determine the preliminary prevalence of data for selected disorder, to assess the logistical challenges, and to raise awareness and advocacy for newborn screening. So, looking into the feasibility result of the study, there was successful collection which was done within 24 to 72 hours of life of the baby by DBS heel prick test in hospital and transported to Switzerland. And out of 5,000 babies sample collected, 4,360 had complete data analysis, and transportation of the DBS to international lab was found feasible and sample remained stable. So, in this study, 2 cases of congenital hypothyroidism and 1 case of cystic fibrosis was detected. So again, giving the prevalence from 1 in 5,000 babies to have congenital hypothyroidism to 1 in 2,500 babies to be having CH diagnosed. And the study was also able to calculate the first and the 99th reference percentile between the Swiss and the Nepalese baby, and they were likely, the difference were there, likely due to the survival rate of preterm infants and feeding practice. So the recommendation from this study was to establish a local testing capacity, to develop a national policy and framework formulation, supporting the infrastructure development and funding support, to conduct a larger multicentric study to integrate newborn screening within the existing maternal and child health program, and to strengthen training, awareness, and advocacy at all levels. And the significance of the study, of course, this was the first study which was done using the dried blood spot test in such a large number of babies from Nepalese population. And this study gave us the foundation for future national newborn screening program. And newborn screening is feasible, acceptable, and essential in Nepal. And it encourages international collaboration and capacity development. The second last study is the feasibility of clinical newborn metabolic screening in a high-volume maternity center in Nepal, and I'm happy that the authors of this paper are here with us in this hall. This was done in the year 2024 and published in the in February, and it was conducted in Parupakar Maternity and Women's Hospital, which has a birth rate of approximately 24,000 births per year, and it covered 825 parents, consented newborns. Heel prick was collected, sample was collected within 24 to 48 hours, and it was sent 3 to 4 times per week to private screening lab in India, and it was tested for 6 candidate conditions, including congenital hypothyroidism, congenital adrenal hyperplasia, G6PD deficiency, galactosemia, sickle cell disease, and biotinidase deficiency. And the 13 newborns screened out of those 825 babies were having abnormal results. So there were screened 3 cases of congenital hypothyroidism. Now from 1 in 2,500, we are having evidence that 3 out of 825 babies to have congenital hypothyroidism, and 2 having G6PD deficiency, 1 with congenital adrenal hyperplasia, 1 with elevated acyl carnitine, 1 with biotinidase deficiency, and 5 with different hemoglobinopathies. So the study also surveyed the healthcare providers, and among the 116 surveyed healthcare providers, 67% of the healthcare provider, they reported the moderate understanding of newborn screening, and all thought that newborn screening was beneficial. So the challenges that were identified in this feasibility study was, again, cost of screening. For these 6 disorders that were screened, the charge that was there published in their literature was Nepalese rupees 27.91, which is approximately $21, and they were also offering a high-risk expanded panel for $43. So the challenge was, number 1, cost; number 2, lack of domestic screening lab, due to which we had to send the sample to the other facilities in India or other labs; difficulty in contacting the families for follow-up of positive results. So once the results were positive, the challenge was again to get the parents back with the baby for further confirmation and treatment. The parental choice strongly was influenced whether screening was provided for free or they were charging. So the parents were willing to make their baby participate in the program provided the newborn screening was free of cost. And the final study is the consolidated newborn blood spot screening effort in the development country. And again, we have authors from this paper here in this hall who were a part of this meeting. The Asia Pacific Society of Human Genetics formed a working group consisting of representative from countries with less than 50% of newborn screening coverage to promote collaboration. And Nepal hosted the 7th APSHG workshop on newborn blood spot screening in Kathmandu on 2nd to 5th September 2024, which was organized by Philippines Newborn Screening Reference Center in collaboration with the U.S. National Newborn Screening and Global Resource Center. And the major challenges that were highlighted in this during the meeting was funding limitation, infrastructure development, training for laboratory and clinical staff, and advocacy to policy makers. And the success factor in the meeting that were highlighted was international technical support, regional cooperation, and engagement of local health care system would make the newborn screening a possibility for the country. So in context to Nepal, the findings that were highlighted during this meeting was that with a population of approximately 31 million and the birth rate of approximately 60,000 babies per year, Nepal is geographically and culturally a diverse country with more than 140 ethnic groups. The national newborn screening coverage are very limited, and mostly we saw was confined to pilot study, with 2 major pilot study which studied about the dried blood screening. So the pilot study, which I have already mentioned and discussed earlier, were also discussed in the meeting. The challenges that were highlighted during the meeting was we have limited domestic lab for confirmatory testing, the cost of screening again, difficulty in the follow-up of positive cases, especially in the remote areas, and low awareness among parents and providers. And especially prenatal counseling was considered to be more effective than postnatal counseling. So if we want to counsel a parent for their babies to be screened, if we are counseling the parents during the prenatal time, the acceptance rate was found to be higher, 72 versus 40 for the pre versus the postnatal counseling. So the progress was that Ministry of Health has allocated budget for the phase 1 newborn screening implementation, and donation of equipment and staff training was done at Parupakar Maternity Hospital, and the future plan is to expand it to the access to remote and mountainous region and to strengthen the prenatal counseling. Here, what I would want to highlight from this slide is government and hospital officials emphasize the importance of mental health during pregnancy and childbirth as a comprehensive newborn and maternal care service. So screening program implementation is integrated with mental health OPD service targeting pregnant and postpartum women at Parupakar Hospital. So there is our challenge, which remains for scaling up, including expanding coverage, personal training, and public awareness. So this has already been mentioned that approximately 2,500 tests were provided at a maternity hospital, and a newborn screening committee with 9 members were formed, and the personnel involved with the testing were given trainings, and authors highlighted that government-sponsored program is the key to establishing sustainable newborn screening in Nepal. So the strategic priority that came up with this meeting was that while newborn screening program can develop in settings outside of the public health system, like in academic setting, ultimate goal of sustainable and universal access can only be attained within or in collaboration with the public health system. Unless we have public health system involved with this program, newborn screening would not be running at a sustainable pace. So we need to move from hospital-based pilot study to national program via Ministry of Health budget, regional lab, legal policy framework, and to expand it to other remote provinces. And this meeting what we look forward to is all of us coming together to build a roadmap for the newborn screening program in Nepal and give a fair chance to life to all the newborns that are born in Nepal. Thank you.
Thank you, Dr. Vijay Mishra, for compiling up many studies from Nepal. Thank you so much. Please continue creating awareness and continue building up data at national level and globally. Thank you. So if you have any questions, please jot it down and we will discuss it during roundtable session.